Hello, everyone, and welcome. The American Academy of Audiology would like to thank you for joining us on today's webinar, Dizzy Patient, So Many Test Choices, How Do I Get It Right? My name is Kathleen Bishop, and I am the moderator for this presentation. This presentation will last approximately 1 hour. Before we begin, I would like to say thank you to those who donated their AAA 2020 and HearTech Expo conference refunds to the American Academy of Audiology Foundation's Educational Fund. We appreciate your support. I would also like to go over a couple of items. First, a copy of the slides can be found in the Handout tab on the webinar page. If, at any point during this presentation, the audio and slides do not appear in sync for you, please feel free to follow along using the slide handout. In addition, please remember that you will need to return to the main webinar page to access the evaluation, assessment, and certificate. In order to receive CEUs for this web seminar, you must view the entire program, complete the assessment, and complete the evaluation. For those attending this presentation during the live recording, please be sure to record the 4-digit passcode found in the chat box following this introduction. This passcode is required to access and print a certificate documenting real-time live participation in the webinar. All other viewers will be able to print the on-demand CEU certificate after successfully completing the assessment. Last, there will be time for questions at the end of this webinar. Please feel free to type your questions for the presenter in the chat box located on the left of your screen as you think of them. But again, we will hold all questions until the end of the presentation. And now, I am pleased to introduce today's presenter, Stacy Morrow. She is a clinical scientist and senior manager of global product management responsible for the balance portfolio for Natus. Welcome, Stacy, and now I'll turn it over to you.
Thank you very much, Kathleen. Good day from wherever you are, whether it's morning or afternoon. I hope you're very safe and well, and thank you for taking the time to join us today. We're very excited to be able to continue information sharing and educating at this time. As Kathleen mentioned, today I will be talking about the dizzy patient. There are many tests that we can complete to aid the diagnosis of a dizzy patient, and we're going to talk about some of these today. We're all very limited for time in our clinics, and we want to make a choice that leads us to the most amount of information. But how do we make that choice, and is it the correct test, and which one will bring us the most information is some of the points we'll cover today. So let's get started. So first of all, let's talk about what we hope to achieve. The learning objectives from today are to evaluate 4 tests. We've got acronyms here. HIMP, which is the head and pulse test. SHIMP, which is the suppression head and pulse paradigm test. VVOR, which is the visual enhanced vestibular ocular reflex test. And VORS, which is the vestibular ocular reflex suppression test. We're going to talk about each of these tests and also talk a little about how to have a more efficient, improved test workflow and how this will benefit both your clinician and your patient. So when our patients come to visit our clinics, we mostly start off with a full VNG. So this is the bread and butter of our balance diagnostics. We start by checking eye movements. We look for conjugate movements or any growth abnormalities. And we move to oculomotor testing. We start with our spontaneous nystagmus, looking for any kind of vestibular imbalance from the asymmetry in tonic firing. Spontaneous nystagmus is the movement of the eyes without any cognitive, visual, or vestibular stimulus. Vestibular nystagmus is usually suppressed by visual fixation, and therefore we deny fixation through testing to look for localization of the abnormality, if one exists. We complete our optokinetics, random saccades, and tracking. In terms of everyday, saccades are required when you want to shift your gaze to a stationary object, whereas tracking is used when you want to follow a moving object. Saccades are much faster eye movement than tracking and can be made voluntarily or reflexively. Tracking, however, is only made voluntarily. Interestingly, it's actually impossible to track an object if there's not one there to track, and your eyes will make a saccadic eye movement. It's important to remember that the neurological pathways also differ for these movements. Because saccades are so much faster, the motor plan and coordination require an internal feedback loop, whereas with tracking, the brain uses a visual feedback to produce accurate eye movements. We also look at static positional and dynamic positional. Static positional, we look for persistent nystagmus present as long as the head remains in that critical position, and we also look for transient nystagmus that is provoked by moving the head into that critical position. Finally, we do our caloric assessment, our gold standard, which gives us an indication of the asymmetry in the lateral semicircular canals and superior nerve innervation. As we know, balance is a combination of many inputs. We have the vestibular organs, which detect head and body movements. Our bodies combine these messages from the balance organs with information from our vision and from our senses in our muscles and joints to help us maintain our balance. If there's a problem with any one of these systems, it can result in imbalance or dizziness. So it makes our job a little harder. The typical VNG assessment will localize an abnormality to various parts of the pathway, some of which are listed on the right-hand side of this slide. However, in 60% of cases, they do not show abnormal findings. Therefore, other tests are required to get a full patient picture. So some of those tests we're going to talk about today. So we found clinicians are very lucky. This area is innovating at a very rapid rate. This research has been developed, published, and it assists our clinical diagnostics and help us make a more accurate diagnosis and also a better management plan for our patients. But with all these novel new tests coming out, we ourselves are starting to feel a little dizzy, unsure. What do these tests do and which ones should we be using? We all have a limitation of time. You can see some of the tests listed here on the left that we can choose. And these are not an exclusive list. There's many other tests we can use. For the purpose of today, I'm going to speak about the 4 highlighted tests on the right. And the reason I've chosen these tests is there's a growing trend in their clinical use. They're quick to perform and they don't require a lot of space. So the first one is the head impulse test. This is HIMP, and this head impulse test is performed by moving the head quickly to the side to initiate a vestibular ocular reflex response. The eyes are assessed for the presence of saccades. HIMP can be performed with VHIT goggles, okay, so that's Video Head Impulse Test goggles, and that is using the technology, but they can also be performed without any technology bedside. SHIMP, which is a suppression head impulse paradigm test, measures the patient's ability to generate a saccade to keep with the focus of a target that moves with the patient's head. So this can also be performed with technology as well. VVOR is the Visually Enhanced Vestibular Ocular Reflex, and it's a test of visual vestibular interaction. We'll talk a little bit about what part this evaluates later. The VORS is the Vestibular Ocular Reflex Suppression Test, and it assesses the same neurological pathways as tracking. We've yet to mention one of the most integral parts of our clinical assessment. We went straight into our test battery. However, it's essential that we do a full patient history. It's one of our best diagnostic tools without the need of any technology. Clinical classifications can point us in the direction of a condition of the patient, and therefore the diagnostic test required to help us detect if there's an abnormality. This image that we've got on the screen at the moment is a great patient toolkit. It's been developed by Vida, and it was used in triaging non-acute dizzy patients for those presenting with symptoms over days to weeks. So anyone who has taken a balance clinic knows that these types of classifications are very useful to help direct our test battery. Although the patient would develop their own conclusions with this tool, we would like to be able to assist in further testing to ensure that the accurate diagnosis is achieved. This gives us a good indication that some of our balance problems do come in classifications. So let's talk a little about the patient history. We want to listen first and then listen second. The most important thing we can do is open questions in a patient history. Gives the opportunity for our patients to speak about their problem. If we do want to ask closed questions to pin down what is meant by a statement, always remember to offer options. The history taken of a dizzy patient is one of the most important things to differentiate the possible etiologies of vertigo. The key factors that allow a first approximation of diagnosis are the time profile, the symptom profile, and the trigger profile of the disease. Here there's a proposed mnemonic, which is So Stoned. We will talk about this on the next slide. It comprises of 8 different dimensions that characterize the vertigo-related complaints of a patient and help guide a clinician into their decision. So each of the letters of the word So Stoned stand for a specific meaning. So S for symptoms, O for often or frequency, S for since, T for trigger, O for etiology, N for neurology, E for evolution, and D for duration. Since the most common vestibular diseases have what we call vestibular fingerprints or classifications, this tool can help to facilitate the identification of an appropriate vestibular diagnosis. All of the classification of vestibular diseases are based upon the ICD-11 beta version of the World Health Organization classification. This classification divides vertigo into 3 different categories: acute, episodic, and chronic. Let's talk a little bit more about what questions can help drive our test battery. So when a patient comes to see us in our clinics, we may want to focus primarily on their symptoms. So what are the symptoms that you're experiencing? Most of the time, our patients may come up with various different words that go into categories such as vertigo, dizziness, nausea, postural instability, falls, that could be with or without syncope, lightheadedness, rotary or linear sensations, tilt, oscillopsia or bobbing, a drunken feeling, to and fro rocking. These are all very important that help lead us into what potentially may be the diagnosis. You may also want to look at how often does it happen. So if there's more than one type of balance symptom going on, you might want to differentiate them at this point. But you can ask about it happening daily, weekly, monthly, irregularly, continuously, or only with a trigger. You also might want to focus on since when has this problem started? If there's more than one problem, again, differentiate them out. And are they related to a particular time and circumstance? Did it start a day ago, a week ago, a month ago, or has it been there your whole life? If we look at triggers, we might want to look at complaints or symptoms that make balance worse. What are your aggravating factors? So is it viral illness, head traumas? Have they had some medical or surgical intervention? Have they had a journey on a boat, a train, or is there no clear cause? We might also want to look at otology and ensuring that all of the otological complaints are documented. So does this person have hearing loss, tinnitus, oral fullness, any kind of hyperacusis, ear pain? And we might want to look at, are these happening before, during, or after the attacks, at the time of the attacks, or completely independent of the symptoms of balance, to be able to ensure that they are related. We also want to look at neurology, and do you experience any kind of neurological symptoms? Now this is particularly important as often we come across a lot of overlap between our vestibular patients and neurology patients. So they may mention headaches, migraines, face or limb paresthesia. They might have phonophobia, photophobia, numbness, palpitations, speech problems. And some of these are unique if having acute dizziness is quite dangerous symptoms. Also, we need to look at what is the evolution of the symptoms. Are they persistent? Have they been improving, worsening, going up or down, fluctuating? And the duration. Are they lasting minutes, hours, days, or can they not remember a time that they have not felt this symptom? So our self-trained approach allows us to cover all of the classifications of these balance disorders. And let us think about our vestibular fingerprint. So once we've completed a good thorough history, our bread and butter of the V&G, and we're still unsure of the test, we need to look at what other tests are required. And this is where we need to consider our vestibular fingerprint. So what parts of the anatomy have not been evaluated and hope to drive any kind of diagnostics to evaluate that part of the anatomy and also to drive the management. So let us first address what each of our chosen focus tests evaluate and add to a test battery. So it's particularly important that we talk about the vestibular ocular reflex pathway, as it's very important in a lot of our tests. So on the left-hand side, we have a schematic view of the pathway, which is showing the basic projections that underlie a horizontal vestibular ocular reflex. We test through the eyes, so they're of particular importance, and you can see on this diagram, your left and right eye. On the middle diagram, we have got a depiction of the neural activity for the vestibular ocular reflex during a head turn to the left. So the grey arrow at the top indicates that left head turn, eliciting a compensatory eye movement, a response to the right. And we have increased activation, which is shown by the dark blue on the slide in the middle. And the thicker orange shows the increased inhibition from the activated vestibular nucleus. On the last diagram, which is C, we can see that when this is not even, so we have a patient here with a unilateral vestibular loss and the head is stationary, that there's an imbalance in the neural activity between the two vestibular nuclei. The absence of a primary vestibular input means that the left vestibular nucleus has reduced activity, which is the light blue, which in turn generates a reduction in inhibition to the right vestibular nucleus, which is that little thin orange line showing that, allowing the cells in the right nucleus to fire at a higher firing rate, resulting in a slow phase of vestibular nystagmus to the left and a quick phase to the right, which is the red arrows at the top. So this is the principles that underlie a vestibular ocular reflex pathway, and it's very important for our head impulse test. So let us talk a little bit about our head impulse testing. So HIMP, or head impulse test, is an angular acceleration. It initiates that pathway we've just spoken about, the VOR. The VOR has two components, one of which the angular reflex, controlled by semicircular canals, will compensate for head rotation. The purpose of the test is to measure the response of the semicircular canals. The semicircular canals are innervated by the vestibular nerve, and that fires at approximately 100 degrees per second on either side in a normal individual. In order to test only one side at a time, it's important to drive the opposite of the contralateral side into inhibition to measure the excitation of that side. And we do that by driving the test at a particular speed. So how we test this? So we test this by asking our patient to look at a fixed target straight ahead. If you're doing this bedside, most commonly people use a nose. You rotate the head to the left or right in an unpredictable fashion using a low amplitude, a high velocity, and a high acceleration motion. The examiner then looks at the gaze of the eyes and determines if a steady gaze is maintained. Patients with a canal deficiency cannot keep up with the high velocity head turns as they do not have sufficient neural firing, and they therefore generate a catch-up saccade to bring them back to the fixation point. And in this case, bedside, it would be the nose. So after an impulse, you formulate a saccade to the affected side to refixate. So the reason why this has become more popular is due to the technology that's now available to us to complete it. We are still looking at the same pathway, but let's look at what the differences between a bedside versus a V-hit with technology are. So there is limitations to the bedside test. It is subjective. It relies on the clinician. It has a low mean sensitivity, and that is because there is clinician error involved in both administering the test but also in reading the results of the test. With technology, we can objectively measure the VOR response with a high sensitivity specificity, which makes the test a little easier, and it's meaning that it's becoming more mainstream. Bedside testing can be variable, and relying just on the examiner to interpret the eye movements means that they can miss the saccades that happen whilst the head is still moving. Those saccades are known as covert saccades. New technology such as a video head impulse test can pick up on these as they have high-speed cameras and a feedback mechanism to ensure that you're doing it at the correct speed, which is really important. The correct speed means that you overcome ocular motor pathway and into the reflex neural pathway, the one that you want to assess. And it allows consistency and accuracy in results. So what can it bring to our test battery? Let's look at some results and what indicates abnormal versus normal and how that would fit into your clinic. So the results on the screen indicate a hex plot. The hex plot will look at measuring all 6 semicircular canals. So you've got your left lateral, right lateral, your left posterior, your right posterior, your left anterior, and your right anterior. It measures each semicircular canal independently, allowing information regarding not only horizontal but the vertical canals and also the superior and inferior portions of the vestibular nerves. So it's important to know how to interpret the results. On the hex plot, you can see that there's various different colours. Each of the colours stands for different things. So our blue is on the left, and this is the blue is the left head movement. The green is the eye movement, and the red on the left-hand side indicates saccadic eye movement or catch-up eye movement. You can see on the right you've got a right head movement, which is an orange, green eye movement again, and red also indicates saccadic movement. So what we would expect in a hex plot, which is the most simplistic view of this, is we'd expect to see that all patients who were normal would have a normal, have a gain of close to 1 and no consistent catch-up saccades. So head over eye, so that would be the blue and green would marry up, and we would have no red on that trace. And on the right side, it would be the orange and the green marry up and no red on that trace. So that's what a normal result would look like. If we look at the hex plot, the right anterior, the right lateral, and the right posterior all have normal results. So that indicates that there's no abnormality in those semicircular canals. However, on the left side of the hex plot, this is not the same. We can see that the head and the eye movements don't overlap, and we have a decreased eye movement gain as compared to the head movement, and we have many catch-up saccades. Patients with canal deficiency cannot keep up with the high velocity turns as they do not have the sufficient neural firing, so they need to generate that catch-up saccade, which is indicated as red on the diagram. And that is towards the affected side to refixate. So remember that decreased gain and complementary saccades is an indication of pathology. So often I get asked the question, does this replace the caloric test? And it's important for me to talk about this because it does not replace your caloric test. It's like comparing apples and pears. The description I use when I describe the difference between a caloric and a V-hit, although they both look at the VOR response and both of them look at the lateral semicircular canal, one is looking at ear-specific testing, which is a relative measure of right versus left, so that's the caloric, and they're looking at a really low frequency of 0.003 hertz. The V-hit, it's also ear-specific and looking at an absolute measurement of right and left, and what I mean by that is it's compared to normative data. It also assesses all 6 canals, not just the lateral semicircular canal, and it's actually at approximately 4 to 5 hertz. So the frequency is important because 4 to 5 hertz is approximately more functional of what we would do or use in everyday life. And I try to describe the difference between the two tests like I would do an audiometer. You would not compare the results of a 250 hertz audiometer to a 4 kilohertz audiometer and expect the same results. We have the same on our caloric versus V-hit. So it does add an additional part of the test pathway. So let's take a look at how this compares to SHIMP, the suppression head impulse paradigm test. So you can see on the diagram here, on left and right, that we've got HIMP versus SHIMP. So that's head impulse testing versus suppression head impulse testing. The two protocols are similar, but in the HIMP protocol, which is the one we've just been through, the person is required to maintain fixation on an Earth-fixed target during the small, unpredictable passive head movements. Like we mentioned before, healthy subjects will not make any saccades or very, very small saccades. In protocol B, we have the SHIMP, which is looking at an identical movement where you have a small, unpredictable passive head turn. However, the head turn and instructions are a little different as the person must maintain fixation on a head fixed target. So like a spot mounted from their head or a laser projected in front of them, and they need to maintain fixation on top of that. Our healthy subjects make large saccades, so the opposite of head impulse testing. We will go into further description on SHIMP on the next slide. So, suppression head impulse testing. In the standard V-hit, they're looking at the Earth fixed target during the head impulse. If their VOR is not adequate, the patient must make a corrective saccade to return fixation to that target. In the SHIMP test, the suppression head impulse test, the patient stares at the head fixed target during the head turn, and the head turn stimulus is exactly the same as that of the head impulse test, brief, passive, and unpredictable, and it's high acceleration. But in the SHIMP protocol, remember, the subject needs to fixate on a target which is moving with their head, so like a laser projected. And this is important because we look at this new variant because we're expecting to see suppression of the vestibular ocular reflex to dominate. Healthy subjects suppress their VOR frequently in daily life. For example, if I'm reading a book on a bus, are moving, walking and trying to read a sign, that is VOR suppression. We expect to see this saccadic eye movement occur 80 milliseconds from the onset of the head turn. So let's look at what some of these results would look like. So let's just go through these interpretations again. So the first left top trace, remember that we're looking for the head and eye movements to overlap as the normal, with no catch-up eye movements, and they are indeed overlapping, and we can see there's no red on that trace or catch-up eye movements. So the V-hit gain is within the normal limits, which is also what's being shown in the graphical representation on the left of that top left-hand trace. Let me just point that out. Here you can see that there's a grey area. That grey area indicates abnormality. The white area is the normal gain area. So this is a normal V-hit result. That same patient had the results below that, which was the suppression head impulse paradigm test completed. You can see on theirs, directly below, that the gain is within normal limits, and there's a downward overt catch-up saccade with a really large amplitude. So if you look at the colours again, the green eye movements do not reach the peak of the blue head movements, and therefore there's a large catch-up eye movement to indicate that they've caught up with that laser. So if we look at the other side, which is our abnormal V-hit, we can see that the green, which is the eye movement, does not marry up with the blue, which is the head movement. So it's quite a small gain. If we look at the graphical representation next to it, you can see that the average points, which are the crosses, of both the red, which is red for right, and the blue for left, fall within the grey area, indicating that there is poor gain. So the gain falls into the abnormal area, head doesn't marry up with the eye, and you've got a large catch-up eye movement to refixate on that Earth fixed target. So just to recap on that, green eye movements do not overlap with the head movement, and the gain is displayed in that graph, and it's in the grey area, which is abnormal, and we can see there's lots of red catch-up eye movements to bring the subject back to the Earth fixed target. So abnormal gain and presence of covert or overt catch-up saccades tells me that there's a problem in that canal, so those lateral canals. And then if we look just below at the SHIMP results, we can see that the SHIMP has abnormal gain on the left and the right. Okay, so indicating that there is a pathology. However, it's a little bit interesting now. So the left has low gain and very few catch-up saccades. And we can see from the gain graph that the gain is particularly low on the left, so it's right down here. And on the right, it also has low gain, but there is a presence of catch-up saccades, so here, over here. So this brings us to a very important function of our suppression head impulse test, and it's the indication of paralysis versus paresis. So if the covert saccades are present, it's a sign of residual function. So in this case, you can see I've pointed at the red lines on this diagram here, which is on the right lateral, and those covert saccades indicate that the right side has actually got some function left. The left side, however, because they're not able to perform these compensatory saccades, this does not. So whilst compensatory saccades indicate vestibular loss in a head impulse test, anti-compensatory saccades indicate in a suppression head impulse test using a head fixed target indicate vestibular function. So it tells you about how much function is left. The new paradigm is a bit different, but it's also quite easy to explain to patients, and probably easier to explain than the video head impulse test, and gives us that additional bit of information of, has the person got any function remaining? So paralysis versus paresis, and that can help guide our rehabilitation, which we'll talk about a little later. So we also have on the slide now the visually enhanced vestibular ocular reflex test. This is a test of visual vestibular interaction, and it's thought to have inputs both from the tracking, optokinetic, and central ocular reflex systems. Its main purpose is gaze stabilization during natural activities such as walking or running. Normal VVOR allows you to read something like a signpost whilst you're driving or having clear focus while walking and reading at the same time. So if you're walking along a street and you're seeing a signpost, you want to be able to do both at once. It's a combination of your vestibular ocular reflex, your smooth pursuit, fixation, and your optokinetic reflex. So it provides an almost perfect compensatory movement to keep your visual target centered and, most importantly, very clear. The neurological integration of this visual and vestibular input and their reflexes gives us the VVI, which is that visual vestibular interaction, which is fundamental to our dynamic visual acuity and also our spatial awareness to help distinguish between any kind of world motion and self-motion. So what way do we perform this low-frequency head movement? So you can, the way we perform this test is we have asked our subject to stare at a fixed dot on the wall at approximately a distance of 1.5. Their heads are slowly moved, and they're moved at a rate of approximately 0.5 hertz at 10 degrees in the horizontal plane, and they're asked to keep their eyes fixed on a stationary dot throughout the testing. So we can watch this video now, which indicates how this would look on a system. We would hit start on the system. The orange is the head, the green is the eye. You can see in the bottom left-hand box the eye was there. We put our hands on top of the patient's head and we'd move it backwards and forwards, and our patient would continue to look at that fixed dot on the wall. We would expect those both to marry up on top of each other if the process is working as it should do. So let's look at some results that can occur from a VVOR test. So again, if we look at the traces, our green is our eye, our orange is our head, and whenever we move them backwards and forwards at that 0.5 hertz at 10 degree increments, we would expect a normal person to marry up the two. So the top person has a normal VVOR response. The VOR test assesses the patient's VOR with a visual enhancement. Unlike the head impulse test, it evaluates low-frequency head movements, which means that the pursuit reflex acts together with the vestibular ocular reflex to move the eyes contralaterally to the head movement. So you can see the top is that smooth integration of these systems in a normal patient. The left one, so again we're looking at the green, which is the eye, and the orange, which is the head's moving backwards and forwards in that low frequency motion, and catch-up saccades on the left for a left lesion when the head is turned to the right. The left with a left lesion, when the head is turned to the left, you get a right saccade. So you can see the saccadic eye movements, which is the green eye movements on that diagram, which is the second one down. Now if we look at the third one down, which is the right lesion, for right lesions, we have catch-up saccades when the head is turned to the right. We have a left saccade. So if we describe that in what's actually occurring with the anatomy, in the unilateral vestibular loss affecting the left side, there is a reduced vestibular ocular reflex gain when the head is turned to this side. So in the VVOR test, when the head is turned to the right side, both the pursuit and the vestibular ocular reflexes are intact, so there's no abnormal eye movement. On the other hand, the VOR does not move the eyes to the right when the head is turned to the left. Hence, there's a corrective saccade to the right during the head movement to keep on top of that target. So the third image, which you can see is the right lesion, has the same explanation to the other side. Finally, the last image can represent one of two things. You can see there's saccades in both directions of the head turn. During the VVOR test performed in a patient with bilateral vestibular hyperfunction, the VOR does not move the eyes to the side opposite to the head movement. Therefore, there's a corrective saccade beating contralaterally to the head movement for both sides, and that's required to keep the eyes on top of that stationary target. These findings are present in bilateral lesions due to the poor vestibular-ocular reflex gain coupled with the bilateral positive head impulse test. We could say that this was a bilateral vestibulopathy. However, remember that this testing can also indicate mixed damage as seen in cerebral ataxia, neuropathies, and vestibular areflexia syndrome, also known as CANVAS. So in this case, the abnormal VVOR, when performed, would reflect a deficit of the VOR, the optokinetic, and the smooth pursuit. So remember that the last image may represent one of two things. So we have the next test, which is our vestibular ocular reflex suppression test. So this test assesses the patient's VOR during visual suppression. Like the VVOR, it evaluates low-frequency head movements, which means the pursuit reflex moves the eyes in the same direction as the target, while the VOR tends to move the eyes in the opposite direction. Therefore, corrective saccades are needed to keep the target on the fovea in a healthy patient. The performance of this test is done slightly differently. For the vestibular ocular reflex suppression test, subjects were tested in a sitting position and asked to stare at a laser dot on the wall approximately 1.5 meters away. Again, their head is slowly turned at approximately a frequency of 0.5 hertz and an amplitude of 10 degrees in the horizontal plane. The laser dot moves with the patient's head, projected in the patient's head, and the patients are asked to follow the moving laser during the test. So this is different from our VVOR, which is looking at a fixed target. In this assessment, the instructions are quite different, and it's difficult to see on the video, but the laser point is going backwards and forwards across the screen. And our patient would be asked to keep their eyes on top of this. So when the head is moved, the laser dot would also move, and the head and the patient's eyes are asked to track the moving laser. So the results look different, and they look a little bit like this. So this is our vestibular ocular reflex suppression results. Remember that the green is the eye movement, orange is the head movement. In normal patients, non-pathological, the VRS test assesses the patient's VOR without the visual enhancement. Differently from the suppression head impulse test, unlike the VVOR, it evaluates low frequency. So VORS is a low frequency test, and which measures the pursuit reflex in the eyes the same direction as the target. So while the VOR tends to move in the opposite direction. So with the left lesion affecting the left side, you can see the VOR gain when the head turned to this side. In the VORS test, the abnormal VOR gain does not move the eyes to the right when the head is turned left. Hence, there is no need for suppression, since the pursuit reflex moves the eyes to the left to follow the target. On the other hand, when the head is turned to the right, the VOR moves the eyes back to the left. Hence, a catch-up saccade beats the right side to overcome the inappropriate VOR suppression. So in a unilateral loss affecting the left side, you will see a larger corrective saccade to the healthy side when the head is being moved to this side. Okay, so that's different from your VVOR. So if it's on the left, the lesions on the left, you will see a corrective saccade to the healthy side. so the right side, and if the lesion's on the right side, you will exhibit a corrective saccade to the left side, the healthy side. The VOR suppression testing can be used also to test the central vestibular pathways and can give an indication of VOR suppression performance. So the last slide, you can see that there's a VOR-S, so the last set of results here, the bottom ones which have no name on them, these ones. The patient can have a bilateral vestibular hyperfunction because the reduced VOR gain does not move the eye to the opposite side of the head movement, therefore there is no corrective saccade during the head movement to either side, since there's no need to suppress the VOR. So the top one is your normal, followed by your left lesion, which is that corrective saccade, which exhibits that larger saccade to the healthy side. So with the left lesion, it's to the right side, the right lesion is to the left side, and the bottom one is the VOR suppression is not happening. So let's move on and have a little think about when this would be something that we use in everyday practice. So we're going to move through a few case studies. So we may recognise this lovely lady here who's quite well known. So I've just used a pseudonym. So we have Kate here, who's born on the 9th of January 1982, and she's a charity worker. So if we go through the case study using the South Sound approach and looking at our VNG, the symptoms that Kate's experiencing are vertigo followed by some unsteadiness. When we asked how often this happened, she said she'd one prolonged episode and many smaller repeat daily episodes. Since the first episode, she's been having these problems, and before that she indicated that she was fine. The trigger just started out of nowhere. She didn't have anything that set it off, and now she's finding that there is a trigger with the unsteadiness in busy places. She gets a little busy. No otological symptoms. She does suffer headaches, but they do not occur in line with the other symptoms, and she has not had a diagnosed migraine. So the evolution of these symptoms, so since the initial episode, which was the worst episode, she seems to be improving, but the other individual small unsteadiness episodes are quite different. So we want to ask about the duration. So the first episode lasted quite a long time, of 4 more hours, and the other ones are only really lasting when she's out and about and in very busy environments. So this might start to flag some what I would call fingerprint classification. Okay, so we'd start to think about perhaps this person has had a vestibular episode. It sounds like she may have had one, but we want to look at our test results. So we can start off by taking a look at the extract from the patient report. So this patient had a full set of VNG tests done, and the oculomotor results were unremarkable, and they fell within normal limits. So she seems to be performing those quite well. We also have our caloric results. So our caloric results were indicating good function. No abnormalities were detected in the caloric testing. No canal paresis or asymmetry. There was no problems in the fixation index, so no kind of central indications. The patient didn't really tolerate the test very well, but sometimes people don't tolerate it. It's not a very nice test, it can be quite lengthy. And we had no Dix-Hall type, and we had no indications that the patient had any BPV. So at this point, that very classical, perhaps so stoned patient history might have made us think it's a vestibular episode. So at this point, we might want to think, okay, what would we want to do next? We want to think about a few things. We want to think about the limitations of our test thus far. So what we don't know anything about is we don't know anything about the otoliths, although the history doesn't strike us as a very classical otolith history. So if we think about Second thing, the ability to know whether this episode was perhaps like a migraine episode, although she reported that they didn't occur together, and that she's never been diagnosed with a migraine, it was just headaches. But we may want a referral for that. The one thing I would think about immediately is that I only know what's happening with the lateral canals here, and I would want to test the other canals to see whether there's a problem with either of those. So let's go on. We did indeed do a head and pulse test, so we added that to our battery of tests, and we got these results here. So if we think about the results and how we look at them beforehand, we look at the head over eye movements, and we can see that all head over eye movements look good, so approximately a gain of 1, with the exception of our right posterior. Okay, so that would indicate to me, wait a second, this person perhaps has had an inferior nerve neuritis, because they have low gain catch-up saccades on their head and pulse test on right posterior, and that portion, that semicircular canal, is innervated by the inferior portion of the nerve, and we didn't test that using calorics. So calorics is lateral semicircular canal function and superior nerve innervation. So this person did have a diagnosis of right inferior nerve neuritis. Okay, so just remember that when we test with our calorics, we only test one portion of the nerve. So they had a classic history of nerve neuritis, and it didn't appear on our caloric, which indicates us to go ahead perhaps and do our head and pulse testing. What we can do now is we can concentrate our rehabilitation in the vertical canals, making sure that we're provoking vertical movements which are relevant to the rehabilitation. So let's proceed on to our next case. So again, another very famous guy. So this person is Clint. He was born on the 31st of May 1930, and he is retired. Clint is desperately anxious, okay, and convinced he's got some undiagnosed balance problem, and he said that to me immediately as he entered the clinic. The symptoms are general unsteadiness. He's off balance. He's had these problems occurring for many years, about 4 to 5. Wasn't sure if they were there before those 4 to 5 years, but he knows they definitely have been present for at least 5 years. He does have a hearing problem, and he does wear hearing aids. However, with his age, the configuration looks very much like presbycusis. Neurology-wise, he doesn't have any known problems, but he does have a stiff neck. He has got high blood pressure, which again is not uncommon in this age range, and he's got general aches and pains as well. He's got a consistent problem that doesn't appear to worsen or better, and it's always present. Okay, so let's look at our results for Clint. So we've done some of the usual, which is our full VNG testing, and we can see that Clint had some difficulties performing his tracking and his saccades. Even after repeat instructions, he was struggling to perform testing. Okay, so this is the problem sometimes with a passive test. If you're asking someone to perform it and they're struggling, it's difficult to get results. So they're not very consistent, but they don't look within normal limits. So that was problematic. You can also see that we do actually have bilateral hyperfunction on his caloric as well. So I'm starting to think perhaps he has got, quite a big problem, and we might want to think about what way we'd want to rehab this. So 2 tests come to my mind. So the 2 tests that come to my mind are the VVOR and the VORS. So this was the results of the VVOR and the VORS. Remember that when we're looking at our VVOR and the VORS, that the green is the eye movement, orange is the head movement. So we are moving a little bit into neurovestibular scope here. We just need to be able to perform the test and give an indication of what's going on. But it's very important to add to our test battery. So I just want to emphasize that the tracking and saccades were poor, Was it instructional or was it anatomical? We don't yet know. So with the VVOR, we can see that the green and orange, the green's not following the orange, and there is saccades in both directions. And the VORS, the green and orange, so you can see the green is in flat line through the head movement. So this may indicate potentially one of two things. So VVOR may be a bilateral vestibular hyperfunction, or it may be mixed damage, and the VORS as well is abnormal. So what is it that we would want to do next? So what does this make me think? These two have added to the test battery because they have maybe confirmed that I definitely have a problem with the bilateral hyperfunction, but I might want to go on and do some imaging. So I would want to refer outside of my scope of practice and potentially neurology if I could visually see that there was a problem with tracking of saccades. Okay, so they can add to our test battery and kind of indicate where our referrals would go. So let's look at the next case study. This is Richard. Richard was born on 31st of April in 49, and he is an actor. So Richard came into the clinic, and he has got a very unnerving bobbing sensation. So he feels off balance, and there is just a general unsteadiness, but this is a very weird bobbing sensation that he's experiencing, and it's constant problems, and it's been going on since he was hospitalised for sepsis. So he was hospitalised over a year ago, and he felt like he was fine before that. It's never gone away since then. He does find that it's worse definitely as he gets up during the night, and he struggles whenever he's out walking his dog on the beach. He always says that it goes a bit unsteady, and he feels like he has to concentrate a lot more than he used to. He also had noticed it definitely got worse when he felt unwell, and when he had this cold symptoms. So he does have a hearing problem, he does wear hearing aids, and he also suffers from phonophobia with no headaches. He has had this consistent problem since the sepsis, which was about over a year ago, and it doesn't appear to be worsening, but he does always feel like he's on a boat. Okay, so we're thinking classic vestibular fingerprint. Maybe some things are coming to your mind now. Things that would stand out for me here are that bobbing sensation. I would also be thinking about perhaps that hearing problem. Is it related or not? Is that phonophobia maybe linked to a migraine associated vertigo? So these are the things, or is it a bilateral hyperfunction? So these are the things that might be coming up. We're starting to think about that vestibular fingerprint. So unfortunately, he does have a bilateral vestibular hyperfunction. So what's really important about these results that we can see that he did have a negative Dix-Hallpike. He had calorics which were indicative of a vestibular hyperfunction, and this seems like it's at the all boxed off, and we don't need to do anything more. However, it's important that we remember that we are looking for a diagnosis so that we can treat our patients. So the way we manage this is kind of where we want to go with this case study. So it's wonderful that our bread and butter provides us that diagnosis, and we've got it from doing that first-owned approach and our bread and butter, but would any additional tests help us manage Richard? So the Bellamy criteria for the diagnosis of a bilateral vestibular hyperfunction is postural imbalance or unsteadiness of gait, which he has, which worsens in darkness or uneven ground. He ticks that box also. He's got a headed body movement oscillopsia in some patients, so he does have that bobbing, in particular in walking, and he has reported this. So we might want to look at whether or not this patient would need some rehabilitation. So one thing I would want to know from his testing is, does he actually have any function left? So this is back to the something we mentioned earlier, which is the suppression head impulse paradigm test, paralysis versus paresis. So what that actually means is whether it's a partial loss versus a complete total loss. And this will change how you manage the patient. We don't teach compensatory eye movements on somebody who are unable to perform them. So on the left-hand side, we can see that these results are both pictures. The left lateral indicates, so if you look at the colours again, the green, so this on this side. So on the green is the eye movement, the blue is the head movement. We can see that the left gain is low and limited. We've got limited or no function because we don't have any catch-up saccades, or barely none. Okay, so we can see this is a test of what residual function is left, and we can see that there's very little residual function on the left. On the right, the gain is low, and we have some function, okay, because we still have these anti-compensatory saccades. So he will be able to perform saccades, okay. So on the left, it's we would expect that he couldn't, and on the right we could. So what we would ideally do is do this SHIB test, and most of the time these two come out to be the same. For this case sample, I wanted to compare and contrast the two, so I put one of each on this slide. But it's important to drive your rehabilitation, and that is the purpose of all of our tests, to get to manage a good, appropriate management of our patients. So if we think about, why it is that we want to look at novel testing, so we want to look at a targeted test approach. And why is that? Why is it something we want to consider? So the benefits it has to our patient clinical outcome, there are many. Having a patient undergo many tests unnecessarily is quite stressful, and it's also very time consuming. So what we hope to do is we hope that we use patient history, or like SOSTONED approach with our bread and butter. Think about what part of the pathway has not yet been evaluated, and maybe pick a test or select a test that you've got access to that may help in that area. And the purpose also is to ensure that you're clinically aware that these tests also exist, so that you can seek to perhaps use them in the future. So what we want to do is derive the most appropriate management with the most appropriate diagnostic tests. So this also adds to service efficiency as well. So it's not just good for clinical outcomes, but it means there's less time spent on lots of unnecessary tests within the clinic, and it gives you more time to focus on appropriate referrals and into other areas, and also to just focus your time on the patients that require your expertise. So whether that is to drive the efficiency of referring to another department like imaging to check whether or not there is truly a central issue, or whether it is for you to manage them in your own department. It's also, everything comes down to money, and it also is more financially beneficial if less costs incurred to the patient on a variation of tests that aren't required. So in this current climate, we have got access to more tests than ever, and it's important to keep in line with innovation and keep up with these novel and tests, and to do the most appropriate testing for our patients. So the purpose of today was just to summarise a couple of things. We wanted to go through a series of different tests. So novel testing approaches on some emerging tests, such as the head impulse test, which evaluates your VOR at approximately 4 Hertz, which is what we would classify as functional or real life, and which assesses 6 semicircular canal on both of your nerve innervations. That's the inferior and the superior innervations. And you've got the suppression head impulse paradigm test, which evaluates vestibular residual function, and what's left of that function, and whether or not it's something you want to work with to rehab, or whether you want to put in other rehab goals in place. So that's that paralysis versus paralysis. You also have your VVOR and your VORS, which gives additional vestibular ocular reflex information at a low frequency, okay, which can help drive your management also. So what we want to look at is we want to look at in the future ensuring that our history directs target testing and that we don't always rely on just a full battery approach of every single test that we have. More target testing improves your patient and comfort. It also allows you to increase efficiency and also has a benefit implication to your patient as well. And don't forget that a central and peripheral problem can concurrently appear in patients as well. That is the purpose of ensuring that once you've got your central and your peripheral information, that you don't realise that can also happen. So I'm going to hand it back to Kathleen. Thank you so much for listening.
Thank you so much, Stacey. It looks like we're just over the top of the hour, so if anybody has any questions, they can email us at continuingeducation@audiology.org. This concludes today's web seminar. The assessment questions and the web seminar evaluation links can be found in the dashboard section of your account. Both of these items need to be completed to receive CEU credit for this web seminar. As a reminder, for those attending this presentation during the live recording, please be sure to record the 4-digit passcode found in the chat box. The passcode is required to access and print a certificate documenting real-time live participation of this webinar. All other viewers will be able to print the on-demand CEU certificate after successfully completing the assessment. To register for any of our upcoming web seminars or to purchase an on-demand web seminar, please visit www.eaudiology.org. Thank you to our presenter today. I would also like to thank you for your participation in today's web seminar. Please note, Academy approval of this continuing education is based on course content only and does not imply endorsement of course content, specific products, or clinical procedure, or adherence of the event to the Academy's Code of Ethics. Any views that are presented are those of the presenter and not necessarily of the Academy. The Academy shall be the copyright owner of any compilation created by the Academy that includes this eAudiology web seminar presentation. All other copyright ownership shall remain with the presenter or the author if using third-party material with permission. This concludes today's program. Thank you. You may now disconnect.